open up for a few minutes for questions that people may have about Evelynn's presentation, Dr. Samet or myself. Any questions, Mark?
So this is a question for Dean Samet. You're responsible for merit and promotion of your faculty. How do you handle the faculty who may be excellent in the policy engagement, effecting change when you're reviewing those packages compared to the traditional measures of publications and grants?
Am I supposed to say thank you for that question? So, I think service, of course, is one part of the academic evaluation. It's certainly part of what the School of Public Health looks at, and there are models and criteria for evaluating the contribution. So this is an important part of what we do. Metrics, of course, are complicated, and how one counts the different kinds of things that lead to impact that constitute practice service is challenging, but this school does it. At least that's my impression in my first 6 months, and it's sort of ingrained in the materials that guide the committees that do these kinds of evaluations. I will say, I think this is not true at all institutions, and potentially problematic for some, and I think within sort of the more academically oriented schools of public health, research oriented, there tends to be perhaps at times too much emphasis on numbers of papers, numbers of citations, grant history and the usual things, and sometimes some of that I think comes because it's easier to measure, and sometimes I think it comes from a culture that is really not sufficiently holistic in its evaluation, or in giving the emphasis should be placed on practice, service, and impact.
Hi. So in regards to access to care and mental health, in general, I work in public health, and in general, we see that even when access is provided and we do referrals with mental health, that stigma is something that still prevents people from accessing mental health. So I was wondering, for the Latino community, was access more the issue that you found, or did you find that stigma was also a factor that was preventing people from accessing care?
And I'm assuming that you mean stigma on the part of the person who needs help or the communities who need help?
Right. So stigma in terms of reception to mental health and all the community factors around that will then prevent the person from wanting to receive the care even when there is access. So was that a factor that you noticed within the Latino community, or the bigger challenge was more that they just didn't have access, but they were willing? Were they reaching for the care but just didn't have access, or was stigma also preventing them from accessing care?
I think it's both. I think it's absolutely both. I think at the broader political perspective is access to care. And stigma, although it does exist in communities and it exists in individuals, in the Latino community very much so when it comes to mental health or seeking help for mental health, is there. It is upon us as social institutions, hospitals, community mental health centers, to really reach out to those populations and not just say, oh, well, there's a lot of stigma, they just don't want help. Because that is not true. There is stigma, but that doesn't mean people don't want help. If I am highly anxious or, I'm depressed, I don't want to go expose my stuff with other people. We Latinos take care of things in our family, but the family are not equipped to take care of those needs. And so what ends up happening is that there's a lot of stress in the family, in the individual, and there's that stigma, but nobody's reaching out. And I can you just ask about something that is very dear and true to my heart. You know, we are really trying to put interventions where we reach out to these populations and talk about stigma related to mental health, stigma related to preventive health. We have a project right now supported by the CDPHE, the Colorado Department of Public Health and Environment, and we developed a video that is Latinas talking to one another and saying, what, you are not going to get that vaccine? You know, and we talk about all the issues that keep Latinas from going to get the vaccine. So trying to target that, but it's not just that needs to be addressed. We need to address, do they have access? So we have a navigation model to provide access. So it really needs to be addressed at multiple levels, the individual, but also facilitating access.
Thank you. One more question.
So I actually had two questions, so I hope I can ask both questions. So my first question is, when Dr. Samet had the graphic up there about addressing root causes, I guess my question is, why are we so hesitant to go deep? And usually the things that I see around root causes, you're just going just below the surface, but what's our hesitancy of going deep in addressing these root causes? And the second question is, when we talk about social determinants, one thing that I think about a lot, and I don't really ever see it addressed, is capitalism. And where does capitalism play a role in trying to go ahead and dictate what you buy, what you eat, and especially in poor communities, and that impact that capitalism has with those communities?
So, two great questions that we could talk about for a long time. I mean, I think, you know, in ways we do go deep, and there are groups that are better at going deep than others. And I think those organizations that, you know, particularly speak at the national level, that are savvy, have the connections within Washington to try and reach those people who are reachable, hopefully that, in a sense, they will do something. When I think about perhaps people within the walls of academia or some other organizations without those connections, it may seem daunting to say, well, how do I go deep? How do I go to Washington? Or how do you address food distribution within cities and try and bring better food to populations within cities? I will say I lived in the center of Baltimore for 14 years, and for the first 11 years, if I wanted vegetables, I had fresh vegetables, I had to go to the suburbs. And then Whole Foods moved in, and guess what? Everybody can't go to Whole Foods and pay for what you might buy there. So, I agree. You're talking about some of the deep roots within our system. You know, for those of you who don't know the work of Sir Michael Marmot, who I think writes about these issues as well as anybody, I would suggest that you read his books. I think his most recent was called The Health Gap. And in fact, there's a little bit about Baltimore he visited. And I think he goes after these, and he's led the commission at WHO and in the UK on this. And again, I think if we can get the highest level attention, perhaps that begins to help. But this has to be multi-pronged, ongoing, and hopefully, you know, as I said, the evidence is there.
I was just going to ask about the work on transgenerational inheritances of trauma responses, because we're looking at a population that has historically been traumatized, is systemically traumatized, and then when you were speaking about the protective factors that they were not necessarily able to sustain as they moved into the U.S., I'm wondering about kind of the continued trauma that these populations are experiencing, and who's kind of looking at that kind of how that transgenerational inheritance of trauma response is continuing to kind of show up in genes and epigenetic factors and kind of long-term health outcomes.
I'm absolutely the wrong person to talk about this, and I was hoping Fernando would do that. You know, there are efforts and certainly work. I mean, what I will actually point to is the ECHO program, which is sort of what came out of the failed National Children's Study, And it's an effort to piece together across the life course by combining multiple cohorts enough data and the right resources in a longitudinal fashion to address the kinds of questions that you're raising. Now, the National Children's Study was ambitious, sort of starting before even originally preconception, to try and track all those factors that might have effects across the life course. There's interesting data on epigenetics and persistence of some early life exposures, maternal smoking during pregnancy being, one example. So perhaps one day we'll be able to begin to answer those kinds of important kinds of questions that you're asking.
Thanks, John. I will add, my work specifically to asthma, but asthma could be an example for chronic conditions, is when you look at over time, people that migrate and you look at the protective factors, is actually lack of acculturation. For example, the people that retain their original language, that have that family network structure, continue to be protected, and that over time is lost. So there's a lot of sort of social, cultural factors that are lost over time, and there's also gain of risk factors. So for example, if you look at in migration and obesity prevalence over time, they go up dramatically, especially Hispanics. So there's a lot of uptake of risk behaviors and loss of protective factors. And in addition to that, things that John mentioned are very, very important, such as epigenetic changes. But it's very complex. It's a great question. Thank you very much to the speakers. Thank you.